Welcome all. We start with today's session. Today we have already started with urogynecology module, and in the urogynecology, today's topic is a bladder pain syndrome. It's a TOG. The title of the TOG is Present Status and Advances in Bladder Pain Syndrome, Central Sensitization and Urinary Microbiome. So we will begin with our quote, Master MRCOG with concept-oriented clarity. So this talk is about bladder pain syndrome. Okay. Last time we have seen about the urodynamic testing. We have also seen about the stress urinary incontinence. We have seen about the pelvic organ prolapse. Now it is the bladder pain syndrome. Okay. So let's see about the overview of the bladder pain syndrome. What is the synonym for the bladder pain syndrome? It is interstitial cystitis. It is defined as a spectrum of urological symptoms characterized by persistent or recurrent chronic pelvic pain, pressure, or discomfort, which is perceived to be related to the urinary bladder and is accompanied by at least one or the other urinary symptoms such as urgency or frequency. So it is actually chronic pelvic pain or discomfort which is related to the bladder and accompanied with the urinary symptoms such as urinary urgency or frequency. Okay, so the other name is interstitial cystitis or bladder pain syndrome. It's a chronic pelvic pain perceived from the bladder and associated with urgency or frequency. The prevalence is around 2 to 6%, more common in women. Phenotype varies from mild to debilitating disease. Mechanism is not known exactly, but both peripheral and central factors are implicated. And treatment includes aims of the treatment are restoration of the function, reduce the relapse, improve the quality of the life, and often requires multidisciplinary care. Now, what is the etiopathogenesis of pain in bladder pain syndrome? Because patient will come with mostly chronic pelvic pain. Okay. Now, the etiopathogenesis is one is a hyperalgesia, which develops due to the inflammatory mediators or cytokines after the bladder injury. So, one of the mechanisms is a bladder injury, which will lead to the release of the cytokines. Okay, and there is associated hyperalgesia. Okay. Now, damage to the bladder's proteoglycan layer, which is a protective layer that leads to the increased permeability and leads to the nociceptor activation. So, pain receptors get stimulated, and this is mainly because of the damage to the proteoglycan layer. Okay, then next is a peripheral injury, infection, trauma, chemicals, surgery, ketamine use, etc. That will lead to the persistent nociception and will lead to chronic bladder pain syndrome. Okay, so these are the etiopathogenesis for the pain. Now, this proteoglycan layer and the treatment. So, this proteoglycan layer acts as a hydrophobic bladder barrier. The damage to this will lead to the sensory afferent activation and neuropathic pain. What is the treatment? The pentosan polysulfate is used to replace the damaged glycosaminoglycans layer. Okay, so this GAG layer is there. This is damaged, and the treatment is a pentosan polysulfate. Okay, please remember this pentosan polysulfate may be asked in a SB. Okay, so one of the pathologies damage to the GAG layer, and the replacement is with the pentosan polysulfate. Pathophysiological trigger factors for BPS generally not asked, but the irritant chemicals, radiation, childbirth, surgery, or instrumentation. Subclinical infection may lead to the mucosal injury. Ketamine cystitis is known to happen that mimics bladder pain syndrome. There is a disruption of the integrity of the mucosa that will lead to the inflammatory mediator release and leading to nociceptor upregulation. Okay. There are central sensitization mechanisms in bladder pain syndrome. Again, the theoretical aspect will not be asked, but just I will go through it. Increased responsiveness of central pain signaling neurons causing amplification of the pain from normal stimuli. So the stimuli which are received are the normal, but there is an increased responsiveness of the central pain signaling neurons. Okay. So basically, in central sensitization, there are central sensitization syndrome such as fibromyalgia, IBS, vulvodynia, migraines. These are the central sensitivity syndromes where there is increased responsiveness of the central pain signaling neurons. So the conditions like fibromyalgia, IBS, vulvodynia, migraines, these are the central sensitivity syndromes. BPS also. Okay, so BPS commonly overlaps with these conditions. Normal bladder filling becomes painful due to altered CNS processing. Okay, now coming to the management approaches targeting the central sensitization. Okay, so there is a pharmacotherapy. In pharmacotherapy, there are two drugs. One is a amitriptyline and second is a gabapentinoids. Okay. Now here there is a difference between the two, not only about the mechanism of action, but also about the preference. Okay. Now this amitriptyline, it acts by inhibiting the serotonin or noradrenaline uptake. So it's a SNRI, you can say, and evidence is 45 to 60% will respond, and it has got limitation of the side effects also. Gabapentinoids acts by calcium channel blockade, but evidence is limited. Okay, there is a risk of dependence and the use is off-label use. So amitriptyline is the preferred drug. Okay, then next are neuromodulation techniques by peripheral neuromodulation such as PTNS and SNS. PTNS is NS is a posterior tibial nerve stimulation. SNS is a sacral nerve stimulation. Okay, so you have pharmacotherapy, then you have neuromodulation. In between these two are also like pharmacotherapy is to be given along with the lifestyle management. Okay, or the behavioral therapy along with the pharmacotherapy. That will be the drug of preferred treatment. If not responding, then we'll go step ladder pattern. Okay. Then mechanism of neuromodulation technique is a gate control mechanism. There is a reduction of the inflammatory mediators, possible opioid pathway activation, and up to 50% symptom relief is seen in neuromodulation. Okay. The next is a deep brain stimulation or DBS, improves urinary symptoms in Parkinson's, potential future therapy for centralized BPS. Okay, this is not a very routine. Then repetitive transcranial magnetic stimulation (RTMS). Randomized studies show reduced pain, improved lower urinary tract symptoms, and better quality of life. It is useful for centralized phenotypes. We'll see this flow chart in us for the stepwise treatment for the bladder pain syndrome subsequently. Okay. The urinary microbiome and the BPS. Urine is not sterile. Okay, it contains resident microbiome. Healthy bladder flora will include lactobacillus, streptococcus, parvotella, gardnerella, etc. And the dysbiosis may contribute to the chronic inflammation and BPS. So this is another etiopathogenesis for this bladder pain syndrome. That is a dysbiosis of the bacterial flora. Okay, so factors influencing the urinary microbiome are menopause, health versus disease, and genetic and geography. Menopause will lead to alteration of the bacterial composition. Okay, what happens in the disease? There is a dysbiosis associated with the symptoms, and genetics and geography will also influence the microbiota diversity. So there is evidence linking microbiome to BPS. Some BPS patients will show bacteriuria at symptom onset. There is a low-grade, recurrent or subclinical infection that may trigger chronic pain pathways. So some amount of low-grade infection is seen in these BPS patients. Now, what about the role of antibiotics if the infection is associated? That we'll see in the subsequent. Whether the antibiotics are routinely recommended, what the RCOG says, that we will see in the subsequent slides. Okay. So here they are talking about the antibiotics in BPS and what is the current evidence. The findings of the earlier trials mentioned there is a little benefit from long-term or short-term antibiotics. More recent uncontrolled studies show there is improvement in the lower urinary tract symptoms and pain, reduction in the bacterial load, and possible role in selected cases only. However, there are limitations. One is a lack of randomized control trials. So role of antibiotic is not through the randomized control trials. Then different diagnostic criteria and outcome measures are there through the evidence, and antibiotic resistance risk will always be there. So what does the guideline suggest? RCG 2016, long-term antibiotics are not recommended. Okay. Newer studies suggest potential benefit, but it needs there is a need for the further research. Okay, so long-term antibiotics is not recommended. So this is what is the flow chart. So when we talk about the management of the bladder pain syndrome, It is a combination of the conservative management with the behavioral modification, and physical therapy alongside with the pharmacotherapy is crucial for the successful management of BPS. I have already mentioned, when you talk about the pharmacotherapy, along with the pharmacotherapy, you have to give the behavioral modification and conservative management. So first comes the lifestyle modification, in which you will have dietary modifications such as avoid caffeinated beverages, alcohol, citrus fruits, juices, spicy foods, tomatoes, etc. Okay, so this all needs to be, or carbonated drinks, these are to be avoided. Then avoid constipation because it can worsen the symptoms of bladder pain syndrome. Smoking cessation is recommended because nicotine is a bladder irritant. Avoidance of urinary tract infection, increase water intake as concentrated urine can irritate the bladder. Then bladder training, avoid frequent micturition just in case to prevent the bladder shrinkage. So bladder training is also important in case of management of the BPS. So this is what is about the lifestyle modification. Then pharmacotherapy, we have seen about the role of gag layer. So the treatment modalities, replacement of the urothelial barrier, which is damaged in these patients. So there is effect on the bladder, analgesic effect on the bladder of this pentosan polysulfate. Okay, so that is a gag layer replacement by the pentosan polysulfate. It acts by replacing the urothelial barrier. There is analgesic effect, but the side effect is a retinal pigmentation. Okay, so remember the side effect of this pentosan polysulfate may come in SP. Okay, then anticholinergics will increase the bladder capacity and reduce detrusor contractions. uh, it what is the effect on the bladder? It controls the frequency, urgency, and urinary incontinence. Okay, so these symptoms will be relieved with the help of anticholinergic drugs, but the side effect will be dry eyes, dry mouth, constipation, etc. Next one we have seen is a amitriptyline. Okay, so the amitriptyline in lower doses will have the bladder relaxation. With higher doses, it will also have an analgesic effect. Okay, so the amitriptyline is going to be the useful drug in management of BPS. It's tricyclic antidepressant. Side effects will include nausea, blurring of vision, skin rash, constipation, diarrhea, etc. Now antibiotics. So low dose long term antibiotic use may lead to symptom improvement. Okay, so this is guideline does not recommend as such what we have seen before, but they have mentioned low dose long term antibiotic may lead to symptomatic improvement in few cases. Okay, now intravesical medication, again there is a gag layer replacement that will provide analgesic effect. Then intravesical botulinum toxin A. Okay, so botulinum toxin bladder injection inhibits acetylcholine release resulting in temporary paralysis. So this intravesical botulinum toxin is also one of the choice for the treatment of bladder pain syndrome. So what we have seen, lifestyle modification, then we have seen pharmacotherapy, in which we have pentosan polysulfate, then we had anticholinergics, then we have amitriptyline. Okay, uh, then comes the this gag layer replacement is there. Then you have botulinum toxin A. Okay, that acts by inhibiting acetylcholine release, resulting in temporary paralysis. Then next is a bladder distension, cystoscopy and hydrodistension. It allows, first by cystoscopy you can confirm the diagnosis. Then hydrodistension, low pressure hydrodistension provides relief of frequency and urgency. Then comes the neuromodulation, in which you have PTNS and SNS. Okay, this PTNS, the fine needle electrode is inserted at the ankle to stimulate the tibial nerve. Weekly sessions for an average 12 weeks is required. Okay, so the patient will have 12 weeks sessions for the posterior nerve stimulation, tibial nerve stimulation. Then is a sacral nerve stimulation. It is implanted nerve device for stimulation of the sacral nerve. It is used for the treatment of severe urgency, frequency, and urinary retention. Okay, so we have seen lifestyle modification. Then we have seen pharmacological therapy. Then we have bladder distension and hydrodistension, and sorry, cystoscopy and hydrodistension, and then comes the neuromodulation. Okay, so this is what is the stepwise treatment for the management of the BPS. Okay, so that finishes the topic of bladder pain syndrome. Thank you.